A hearty good evening and welcome to the session on Azoospermia. We are glad to have Dr. Pratibha Pasari among us today to help us understand the topic. She will take us through that and more in this session today. Doctor, you have the stage.
Thank you so much. Thank you. Hello and a very good afternoon to all. Today I'm going to speak about azoospermia. So, azoospermia is basically a condition when there is no sperm in the semen sample. So, basically, what happens when a patient with infertility comes to us, we first evaluate them that what is the problem, whether the problem is the female infertility or the male infertility. So, is the problem? So, what we do is we evaluate both the partners. We do blood test for both the partners. Then we do sonography of the female partner and semen analysis of the male partner. So, semen analysis is one of the most important and one of the most basic tests which tells us about the problem in males. So, semen analysis is what the male partner has to provide semen sample in the center, which is analyzed in the andrology lab by the andrologist. So, it takes about 2 to 3 hours for them to produce the report. So this semen analysis, the sperm is studied about the various factors like the concentration of sperm in the semen, the sperm count, the motility, the morphology of the sperm, and these various factors are studied to know if there is any problem which is causing infertility to the patient. But one important factor is that there may not be any sperm in the sample. So this condition when there is no sperm in the semen sample is called azoospermia. And when a husband comes to know about it, that there is no sperm in his semen, he is very much apprehensive that he will not be able to be the biological father of his child. So, but if we evaluate the patient, the male partner, very nicely, we see that even in azoospermia cases, we can make the husband the biological father of the child. So, this is an important topic today because today I'm going to give emphasis on how to evaluate a case with azoospermia, how their evaluation should be done to know whether they can become the father of the child. So when the report says that it is azoospermia, then it one report should not label the patient as azoospermia. So according to the WHO, it says that the sample should be repeated at 1 month interval to check. So if the second sample at 1 month interval also says that it is azoospermia, then we label it as azoospermia. And now when we see that the patient is azoospermia, we now want to know the cause of azoospermia. So the sperm, they are produced in the testis under the influence of the hormones from the brain, and from the testis then it passes through the vas deferens, and it gets mixed with the semen in the seminal vesicles, and it is ejaculated. So the azoospermia, it may be obstructive or non-obstructive. That means if the sperm is produced, there may be obstruction in the path from where the sperm is not mixed into the semen sample, or it may be non-obstructive. That means there is problem in the hormones. So let us see what should be done with these kind of patients. So, to know whether it is obstructive or non obstructive, we need to evaluate the male partner henceforth. So, we take the history regarding the family history, genetic history, the sexual history, environmental history, that if it is exposed to any toxins. Now, what is his occupation? If his occupation is in a environment of radiation, that those radiations may be destroying his sperms, or he may have a history of any trauma in to his genitals. So we go for a detailed history of the patient, or he may have undergone any surgery for varicocele, or most important is the patients who have undergone vasectomy for their sterilization, so they don't have sperm in the semen sample. So we need to take a detailed history of the patient regarding their previous history, any medical history, surgical history, drug history. If patient is on any drugs, there are certain drugs which also decreases the sperm count, or sometimes they totally causes azoospermia. So we take the detailed history, then we go for the examination of the patient. We do the general examination first and see the signs of any virilization, or whether the secondary sexual characters are developed or not. And then we go for the local examination of the patient, that is the genital examination. In the genital examination, we see the size of the testes, whether they are of appropriate adult size or not. We do that with the help of a Preda's oxidometer, which tells us about the volume of the testis. We compare the oxidometer with the testis of the patient, and then we get to know the volume of the testis. So in adults, it is about 15 to 25 ml, the normal volume of the testis. So after checking the volume of the testis, we then go for the evaluation, the hormonal evaluation. Now, this is one of the important factor, because uh, in a case of azoospermia, when we go for hormonal evaluation, this will tell us whether the patient is a case of obstructive azoospermia or non-obstructive azoospermia. So, if all the hormones are normal, we go for FSH, LH, prolactin, testosterone. So, if these hormones are normal, then the hormone production is from the brain is normal, then it is a case of obstructive azoospermia. That means the sperms are produced in the testes, but they are not coming out in the semen. So there is some obstruction in the path. We know that. And if there is the hormonal imbalance, one hormone is high, other hormone is less, we know it is a case of non-obstructive azoospermia. So the treatment is different. Let us first see the case of obstructive azoospermia. So, when we have diagnosed there is a case of obstructive azoospermia, we again go for the genetic test of the patient to see what kind of obstruction, or what other problems he may have. So that if we go for further evaluation, we would be able to know that whether the patient really has sperm in the testis, and if he has if he has any genetic problem, whether we are able to use the sperm of the patient or not. So we go for the genetic evaluation. Then we do the ultrasound of the scrotum. Then there are different imaging technologies, like we can go for a transrectal sonography, and also we see if there is any retrograde ejaculation. That means after the patient is ejaculated, we see if the sperm has entered the urinary bladder. So we ask the patient to pass urine after that, and we check the urine sample to know whether the sperm is present in the urine or not. So that is a case of retrograde ejaculation. The ejaculate is not coming out, but it is going behind in the urinary bladder. So after doing all the investigations, we know that this is a case of obstructive azoospermia or a non-obstructive azoospermia. So if it is a case of obstructive azoospermia, that means the patient has sperms in the testis, that is in the epididymis where it is stored. There is an organ above the testis called epididymis where the sperm is stored. So what we do is we go for a diagnostic TESA. TESA is testicular sperm aspiration. We check whether there are sperm in the epididymis or not. If yes, we use those sperms um, mm, to fertilize with the egg through ICSI. That means the patient will have to go for IVF in these cases. In IVF, what we will do is we will take out eggs from the body of the female. We will take the sperms through this testicular aspiration. We will fertilize the egg and the sperm, form the embryo, and then we will transfer this embryo in the patient so that she will have the pregnancy. So, in case of obstructive azoospermia, we can go for IVF, and in this IVF, we can go for testicular sperm aspiration. So there are many types of testicular sperm aspiration, that is either percutaneous, where we just insert a needle in the epididymis, just take out the fluid and check whether there's sperms or not. Then we can go for an incision, where we go in deep into the tissue and then try to find out the sperm. And nowadays, a very advanced technique has come up of MESA, that is microscopic testicular sperm aspiration, where we see the sperms under the microscope with our naked eye in the testis, and then we select those sperms and we go for the fertilization of the egg. Then we get the pregnancy. We form the embryo and then transfer these embryos to have the pregnancies. So in case of obstructive azoospermia, the treatment is this. When we see that it is a case of non-obstructive azoospermia, that is, it is due to hormonal imbalance, we first try medical treatment, giving hormones to the patient. We check whether he has improved or not. If not, then again we have to go. So when if patient is not responding with the hormones, the sperm has not come into the semen, still then few percentage of patients of non-obstructive azoospermia may have some sperm in the testis, and for them we cannot go for this needle aspiration or something. For them we have to go for this microtessay, that is to check under the microscope if they have sperms or not. So if they have sperms, if these non-obstructive cases of azoospermia have sperms in the testis under the microtessay, we use these sperms to go for IVF ICSI and give pregnancy to the patients, and let the father be the biological father of the child. If not, then we have to definitely go for the donor sperm sample for fertilization of the eggs. And uh, if we are not going for microtessay, then definitely the simple solution is going for the donor sample for fertilizing the eggs. So when we get a report as azoospermia, so don't get disheartened that you may not be the father of the child. First, we have to repeat the sample to check to confirm whether you have azoospermia or not. Secondly, we need to find out the cause of azoospermia, whether it is obstructive or non-obstructive. Then go for the treatment as such. Go for medical treatment in case of non-obstructive, and in case of obstructive azoospermia, if the obstruction is as such that we can go for any surgeries, like in case of vasectomy for previous sterilization operations which was done. So that is the only indication in today's world which is recommended for the reversal process, so that the patient will again have sperm in the ejaculate. Nowadays these operations are done robotically also. This is a newer approach, and but the patient must always be counseled that there are chances that the operation may not be successful, and you might have to go for either vasectomy or I'm so sorry, I was on mute. So I repeat, like I was saying that in case of azoospermia, we have to first establish whether it is a case of azoospermia. And yes, if the second sample also says that it is a case of azoospermia, we then have to know the cause of azoospermia, obstructive or non-obstructive. So if it is non-obstructive, that is problem is in the hormones. We give the hormones and check if the patient is producing sperms in the semen sample, well and good. If not, they have to go for IVF ICSI, where we have to not IVF ICSI, which is a more advanced technique in cases of IVF, where we use retrieve the sperm sample by TESA, and then we go for fertilization. And in case of obstructive azoospermia, I was saying when I was mute, I'm so sorry, that if the patient has had vasectomy, the sterilization operation. So today the only indication where we go for surgeries in case of obstructive azoospermia is previous vasectomy, where we go for the reversal operations. But patients should also be explained that it might not be very successful, and later they may have to go for other procedures such as ICSI, where the sperm is retrieved by TESA, or have to go for the donor sample. So the patient should be pre-counseled regarding everything, regarding the modes of treatment, the cost involved, the success rate, everything, and it will be the call of the patient to choose which modality of treatment are they going to use. So this was in short, or maybe I've tried myself the best to explain about azoospermia. If you have any questions, you can ask me. If not, you can connect me through Apollo Fertility and I can solve your problem. Thank you so much.